Hello and welcome to the training on resolving network adequacy issues as part of the CHA certification training series. My name is Catherine Earle. I'm the Quality Assurance Manager for the CHA program, and I'll be introducing these slides, but you'll actually be hearing from all of our specialists in this training. Medicare rights will speak about Medicare network adequacy. The legal aid will speak about Medicaid network adequacy, and CSS will speak about commercial insurance network adequacy issues. So I hope you're looking forward to the training. What is network adequacy? Very important question. It refers to federal or state standards established for health plans to guarantee that they meet certain criteria, such as sufficient number and type of healthcare providers. Network adequacy may also ensure insurance plan members have adequate access to covered benefits within reasonable distance and appointment wait times. So these are really important rules for helping our consumers, our child consumers, access care. The learning objectives for this training are network adequacy requirements, common client issues and strategies to resolve network inadequacy issues for each of the following types of health insurance. So as discussed, Medicare, Medicaid, Child Health Plus, the Essential Plan, and commercial health plans. So I will now pass it off to Medicare Rights Center to introduce the Medicare portion of this training.
Hi, everyone. My name is Lily Schmidt-Swartz, and today we're going to walk through what network adequacy actually means in the Medicare context, and more importantly, what to do when things go wrong. This comes up a lot in our work as advocates. Frequently, we find that beneficiaries cannot find providers, they lose providers mid-year, or are told something isn't covered when it actually should be. The goal is to help advocates spot when a plan may not be meeting its obligations and what tools we have to respond. To start, let's ground ourselves in what Medicare Advantage plans are actually required to do when it comes to their networks. So, at a basic level, Medicare Advantage plans that use networks are required to make sure enrollees can actually access care. Network adequacy means there are enough providers and that people can get appointments in a reasonable time. CMS requires plans to meet these standards and attest to them every single year. The standards can be found linked on this slide. Plans, of course, can request exceptions to these rules, but those are supposed to be limited. An example is if a plan technically lists specialists, but none are accepting new patients, that can still be a network adequacy issue. So we've talked about the bigger picture requirement that plans need to provide access to care. But what does this actually mean? So criteria include that provider and facility specialty types that must meet number, travel time, and distance standards. An example is that the plan must have an adequate number of contracted specialists like ophthalmologists, neurosurgeons, skilled nursing facilities, and diagnostic radiology centers to meet enrollees' needs. The standards for distance and travel time to providers vary regionally and by specialty type. CMS evaluates access to each specialty type by using quantitative standards based on the local availability of providers and facilities to ensure that organizations contract with a sufficient number of providers and facilities to furnish healthcare services without placing the undue burden or hardship on the enrollee seeking those covered services. Medicare Advantage plans are also required to define the types of providers to be used when more than one type of provider can furnish a particular item or service. They are also required to identify the types of mental health and substance use providers in their network and to specify the types of providers who may serve as the enrollee's primary care physician. There are also beneficiary protections. If a medically necessary service is not available in network, the plan has to arrange out-of-network care. They cannot charge the out-of-network cost sharing, rather, they have to charge the in-network cost sharing. For emergency and urgently needed care, it can be covered anywhere in the US and at an in-network cost sharing. The prudent layperson standard applies. So if a reasonable person believes it is an emergency, it has to be covered by the Medicare Advantage plan. The beneficiaries' protections can be found here in the Medicare Managed Care Manual, Chapter 4. There are special enrollment periods that are available to individuals that are in these circumstances. The special enrollment period allows a beneficiary to change coverage outside of normal enrollment periods. A client may qualify if the plan significantly changes its network, or if the plan violates its contract. Timing begins once CMS determines a violation and can extend after disenrollment. You might want to see our Medicare Interactive Special Enrollment Chart for more information about the special enrollment periods that exist for Medicare Advantage and Part D enrollees. Now let's take a bit of a closer look at how SEPs work, specifically in the context of network changes and violations. If a Medicare Advantage plan stops contracting with many in-network providers and CMS determines determinations are substantial enough, the beneficiary has a one-time special enrollment period to enroll in a different Medicare Advantage plan or to switch to original Medicare. The special enrollment period begins from the month the beneficiary is notified of the network change and then will last 2 months after that. The plan is required to give at least a 30 days notice so that the beneficiary has time to use their special enrollment period. The beneficiary will have a special enrollment period if their Medicare Advantage plan or Part D plan violates a material provision of the contract. This can include giving misleading marketing or info about the plan's network. And the SEP to switch to another Medicare Advantage plan or Part D plan begins once the regional CMS office has determined that a violation has occurred. There is the Medicare Advantage and Part D enrollment and disenrollment guidance for more information. There are many different types of network issues that can occur. First, that there's not enough providers in network. That is a very common one. We also frequently see that a beneficiary wants to see a specific provider, but that provider is out of network. That provider directories are not up to date, also common, and provider network changes happen during the year. We have an example of a case. So Flora is enrolled in an HMO Medicare Advantage plan. She has been seeing the same physical therapist for years, but she recently got a notice from her plan that they are no longer in network. So it seems like this is a middle of the year change that is happening with her provider directory. She's having trouble finding another in-network provider who's accepting new patients. What are some strategies that we can use to help Flora? You might want to think to yourself about the different things that we spoke about in ways that beneficiaries can be protected. So first, we're going to contact the plan or use the online provider directory to see if there is a list of in-network physical therapists so that we can confirm whether there's a different physical therapist that might take new patients and see Flora. If not, then it's always helpful to file a complaint with the complaint tracking module with Medicare. The complaint tracking module can be found on Medicare.gov's website. Flora might want to consider changing coverage during an available enrollment period. There's the Medicare open enrollment period, which is every October 15th to December 7th. There is the Medicare Advantage open enrollment period. And then there's also the special enrollment periods that we spoke about, as well as many different other special enrollment periods. Before enrolling in the new plan, Flora should contact all the providers she knows that she wants to see and ask if they're in network. Getting that double confirmation from the provider is helpful since provider directories may be outdated from Medicare Advantage plans, and provider offices really will have the most up-to-date information about which Medicare Advantage plans they accept. There are some additional strategies for Flora, so she might want to file an appeal. And some examples of reasons to appeal is that the Medicare Advantage plan denies coverage for out-of-network emergency care or beneficiary receives out-of-network care due to incorrect network directory, or that they were referred to an in-network provider to get out-of-network care, or you could not find an in-network provider. These are other strategies that one can use if they are facing network adequacy issues. You might want to see the Medicare Appeals and Consumer Protections trainings that we did for more guidance on filing a successful and timely appeal.
Morning, everyone. I'm Elizabeth Logan, and we have Lillian Ringel on the phone. And we're going to cover today's training will be on Medicaid network adequacy rules and how to resolve network issues. And before we go to the next page, I just wanted to explain a little bit about what network adequacy is. And essentially, network adequacy means health plans must have enough doctors, hospitals, and providers in their networks so that members can actually get care without unreasonable delay or difficulty. In other words, it's about whether the plan's provider network is big enough, close enough, and available enough to serve its members. So now that we know what it is, let's discuss what the network adequacy requirements are in the state of New York. And on the next slide, we'll start. So network adequacy contractual requirements are not just about whether a provider is listed in the directory. The state looks at whether the plan's network is sufficient for the population it serves. For Medicaid managed care, HIV SNP, HART plans, these requirements are found in Section 21 of the provider network of the mainstream model contract. MLTCs have parallel requirements under the MLTC partial capitation contract, with the most recent available here at this link. All right, so New York State reviews networks of all contracted managed care organizations for three key standards, which are availability, accessibility, and adequacy. Availability asks whether providers exist in sufficient quantity. Accessibility looks at whether members can realistically get to them, and adequacy examines whether the network overall can meet enrollees' needs. Additionally, plans must offer an appropriate range of preventative, primary, specialty, and long-term services and supports adequate for the anticipated number of enrollees for the service area. They must also maintain a network of providers sufficient in number, mix, and geographic distribution to meet the needs of the anticipated number of enrollees in the service area. You can also refer to the New York State Department of Health guidelines for managed care organizations found at this link. Next slide. Okay, so Medicaid network adequacy requirements as it refers to behavioral health. There are new network adequacy regulations for behavioral health services that went into effect on July 1st, 2025. Now, initial appointments for behavioral health must occur within 10 business days of the request or 7 calendar days following a hospital discharge. If the plan cannot meet expected timeframes, they must offer out-of-network mental health or substance use disorder coverage without increasing costs for consumers. And so, in essence, this would be like the plan would refer an out-of-network provider at the rates of their in-network providers. Plans must also update provider directories with details regarding practice locations, provider affiliations, restrictions on scopes of services. There are also regulations that apply to only certain types of providers 90 days after the commissioner determines there's enough of these providers in the state to meet the standards, such as assertive community treatment providers or mobile crisis centers. Enrollees who can't schedule an appointment within mandated timeframes can file what's called an access complaint. They could do this by phone or in writing, And they do this with their plan. And the plan is required to respond within 3 business days to an access complaint by either locating a participating provider or informing the enrollee that there is no available participating provider, but the plan will approve an out-of-network provider. Plans are not required to directly assist with finding participating providers, but plans may give contact information for the behavioral health ombuds, which is called CHAMP, so they can get assistance needed to locate one. And also, there are new regulations that have that plans are required to have designated staff with sufficient knowledge to help enrollees find participating behavioral health providers that treat the enrollees' specific behavioral health conditions, and then provide contact information for that. So the key takeaway here is that these new rules strengthen access protection because behavioral health access has become one of the biggest statewide network problems. The key point is that the obligation is no longer just a directory compliance, like it may have been in the past. Plans must secure timely appointments for individuals. And if they cannot, the enrollee gains the right to an out-of-network provider or out-of-network care without additional costs to them. Next slide. Okay, so Medicaid network adequacy requirements with regards to service area and geography. Sorry, I'm getting text messages. For mainstream Medicaid plans, members must have a choice of 3 geographically accessible primary care providers. For this reason, managed care organizations must contract with a minimum number of specialist provider types in each county where available, and that's based upon the population or the caseload ratios. For the MLTC partially capitated plans, these plans are required to, they require a minimum of 2 providers who accept new enrollees in each county in the plan service area for each covered service, unless the county has an insufficient number of providers. So the service areas are defined as a county, except in New York City, where New York City basically covers all 5 boroughs. But in counties with lack of healthcare resources consistent with consumer utilization patterns, service areas may include the county and portions of the adjacent county, usually at an average of 10 miles or beyond the county border, and it can extend up to 30 miles. For rural areas, county service areas may extend to the closest available provider. And with regards to time and distance standards, you can refer to the model contract under section 15.5, but generally it's from the member's residence to the available participating provider. For metropolitan areas, travel distances should be no more than 30 minutes by public transportation. For non-metropolitan areas, 30 minutes or 30 miles by public transportation or by car. And in MLTCs, 30 miles from the enrollee's residence. And rural areas, transportation requirements may exceed these standards if it's justified. You can go on to the next slide. Keep in mind, so on this next slide, we have Appendix G of the MLTC partial capitation model contract, which breaks down which services are covered by the plan's capitation and which are carved out and paid fee for service. And this is critical when determining whether a network adequacy issue is actually the plan's responsibility. So before raising a network adequacy argument, always confirm whether the service is even included in the plan's benefit package under Appendix G found here. Next slide. So the next couple of slides, we're going to discuss consumers' rights. So no in-network provider available. So if the plan does not have a network provider available, who has the right training or experience to meet the enrollee's needs, or they can't offer an appointment, then the plan must refer the enrollee to an appropriate out-of-network provider. Consumers have the rights to referrals. And so the referral has to follow a treatment plan approved by the plan. And then the plan must consult the primary care provider, the out-of-network provider, and the enrollee or their designee. They have the right to go to an out-of-network at no extra cost. Enrollees are entitled to receive specialty care from an out-of-network provider if the plan doesn't have a qualified in-network provider. And according to New York public health law, the enrollee does not have to pay more than they would if they stayed in network. Enrollees have the right to parity with their physical health rules. And essentially, plans cannot impose stricter requirements like extra paperwork, more evidence, or approval hurdles for accessing behavioral health services from an out-of-network provider than if they were to go to like a regular doctor for their health needs. And that's under New York federal law 42 CFR 438.90. So in short, this guarantees enrollees can get timely behavioral health care even if the plan's network is limited, and the plan must facilitate access without extra costs or barriers. Next slide. So continuing on with consumers' rights. So emergency services. Enrollees are entitled to access unrestricted emergency care out of network if needed. And under New York insurance law, the prudent layperson standard states that if an enrollee reasonably believes that they need urgent medical care, they can go to the ER, even if the ER is out of network. New enrollees have transitional care rights. They're entitled to receive ongoing treatment for serious conditions. Enrollees can continue an ongoing course of treatment with an out-of-network provider for up to 60 days from their enrollment if the condition is life-threatening, degenerative, or disabling. Enrollees have pregnancy-related care rights. If an enrollee is entering their second trimester, they can continue care with an out-of-network provider through delivery date up until 60 days postpartum, and that's also under New York public health law. And finally, for current enrollees, when a provider leaves the network, they are entitled to receive ongoing treatment continuation if a current provider leaves the plan network. The enrollee may continue treatment with that provider for up to 90 days after being notified. So, and that is the date that they are notified. So if their provider leaves the network and then like a month has gone by, it's the date that they received that notification. And then pregnancy-related care for enrollees in the second trimester through delivery, they can continue care with the former provider through 60 days. And this is all under New York Public Health Law 4403. So the key takeaway here is that new or current enrollees have protected access to care with out-of-network providers in emergencies for transitional care or during pregnancy without any extra costs. And this ensures continuity of care when network limitations or provider changes occur. And that concludes the section on Medicaid network adequacy, and Lillian will continue on with how to resolve network issues.
Thanks so much, Liz. Hi, everybody. All right, so we will move on right ahead. Uh-oh. There we go. Okay. Common network issues that you might encounter, that your clients might encounter. So one is a variation in network quality. Sometimes in-network providers, let's say, may provide a poor quality of care, for instance. Or does someone have reasonable, do reasonable transportation options exist? Are there alternatives to network provider locations? What about the language and cultural competency of providers who are in network? If you are let's say you are a Russian speaker and you live in an area where there aren't any Russian speaking providers. That's problematic. Or the office staff doesn't speak Russian, that's problematic. Timely scheduling for non-urgent appointments. How long does it take you to get in once you call to make your appointment? Access for people who have disabilities to all network providers. This is one we see a lot, the accuracy of provider directories. A lot of those provider directories are now available online, but that doesn't necessarily mean that plans update them in real time. So there may be providers whose names are listed on these provider directories who aren't actually accepting new patients. And then, as Liz was discussing earlier, covered versus non-covered services under the managed long-term care program. Okay, so what can you do if your clients are experiencing network adequacy issues? First things first is you want to contact the plan, and you want to do so by filing what's called a complaint or a grievance. To do so, you are going to want to refer to their member handbooks or to call the plan's member services phone number to find out how to file a complaint or a grievance. Medicaid managed care plans are supposed to have case managers who assist clients who are having trouble finding in-network providers. Depending on the plan, depending on your client's existing relationship with their case manager or care manager, they may or may not find that useful. They also are supposed to have a complaint or a grievance phone line, as well as a process to both receive and respond to complaints or grievances. If you eventually move past the plan and you have to file a complaint with the state, in order to do so, if your client is in a mainstream plan or a health and recovery or HARP plan, you can contact the New York State Department of Health Managed Care Complaint Unit. We've put a phone number as well as an email address here and a mail address. We have a couple of links to complaint templates, one a general complaint template, the other one specifically about dental network adequacy. One just tip to keep in mind is that, and this is just my own belief, but I think filing email complaints is often easy. I find them easiest to track, and that I get sort of the most efficient resolution with an email complaint. So that's just my 2 cents. And if your clients are enrolled in a managed long-term care plan, you can call the phone number listed here or email the MLTC complaints email address here. We also have a regular postal address listed here as well. Just to emphasize the importance of filing complaints with the Department of Health about network adequacy. If the Department of Health doesn't see complaints about network adequacy, it's going to assume that there just aren't any issues. But I think, we all know that there are issues. So if your clients are having network adequacy issues, please complain. And the reasons that you might consider complaining, and we'll go into them a little bit later, is if the plan doesn't have an in-network provider who has the appropriate training or experience to perform the service, or if the service itself is materially different from services available in-network, and you're likely to get a more clinically beneficial outcome from one of those out-of-network services, or if there's no in-network provider in a consumer's area that has an available appointment, then you can start this process of filing a grievance, filing a complaint, and if unhappy with those results, complain to the Department of Health. And one more thing just to flag is that plans have to decide grievances within 90 days. Finally, if you were not, if you or your clients are unable to find an in-network provider and you have found an out-of-network provider who will serve you, or excuse me, your clients, contact your plan to ask them to help you coordinate that care. And if that doesn't work, you can also ask the provider's office to submit a prior authorization request for the requested care to your client's Medicaid managed care plan. Your plan may, or your client's plans may ultimately deny the request because the provider is out of network. But when they do, they're required to send a written notice explaining the denial and how to appeal it. And if your plan denies an out-of-network referral, that will go, we'll go into this a little bit later, you'll have to show that the plan does not have an in-network provider with an available appointment, the appropriate training and experience to meet your healthcare needs, etc. So there are ways to appeal those denials. Okie dokie. Here are a few templates for network adequacy complaints and grievances. We've linked to them here. And this is within Medicaid managed care. Okay, so as I was saying, if someone's plan does not have an in-network provider who has the appropriate training or experience to perform whatever the service is that your client needs, or if the service itself is materially different from the services available in network and is likely to produce a more clinically beneficial outcome, what you can do is file an appeal for an out-of-network referral and an out-of-network service. So that's if your plan is issued a denial, you can file a plan appeal for an out-of-network referral and out-of-network service. If you are then denied again, you can file an external appeal just as you would for any other kind of in-network service denial. So out-of-network referral denials are common, and you may, or your clients may actually win on these external appeals, because what happens when plans deny out-of-network requests is often in their denials, they will send a list of, call it a handful, 3 or 4 in-network providers who the plan thinks you can contact. Well, if you call those in-network providers, or if those in-network providers are in any other way, inadequate, let's say they're out of your geographic area or transportation area, etc., you can win on an external appeal, because often the reviewer, when they are conducting the external appeal, and this is something you would want to draw their attention to, will call each of those in-network providers listed in a final adverse determination and use the information that they get from them to determine whether or not the plan's denial was reasonable. If providers don't have appropriate training and experience to perform the service, or they're otherwise not available, then your external appeal should be successful. And as I was saying, not available may mean being too far away, they may be on leave, they may not be accepting new patients any longer, it may take too long to get an appointment with them, etc. You also have a fair hearing option if you lose on an internal plan appeal. You can pursue a fair hearing either in lieu of or in parallel to an external appeal. But remember, as with any other fair hearing, you want to consider that the fair hearing decision will take precedence over an external appeal decision. So if you get a good decision on an external appeal, you should not move forward with a fair hearing, because if that goes sideways, that fair hearing decision is going to take precedence over the external decision. It's also taking some time to schedule fair hearings, whereas once you submit an external appeal request to the Department of Financial Services in the state, once they have all required information and send your external appeal off to an independent reviewer, they have 30 days for a standard appeal to get back to you. That may be shorter than scheduling and then getting a decision on a fair hearing. So these are all things to keep in mind. Okay, so let's go through a case example. Finding a local provider. Your client is a Medicaid recipient who is in her late 40s and she lives in Brooklyn. She has diagnoses of multiple sclerosis and seizure disorder. She walks with a cane and fears having a seizure while she's traveling on the subway. She prefers to see providers who are in close proximity to her home. After suffering a stroke and being hospitalized, she's discharged and referred to an in-network neurologist for follow-up. That neurologist's first available appointment is 6 months away. By the time that appointment day arrives, the provider is now out of network. She tried to find someone in network in Brooklyn, but with no luck. So she made an appointment with an in-network provider in Manhattan, 1.5 hours away by bus, subway, and then another bus. What are some advocacy steps you can take? One is you should contact the plan. Since she lives in New York City, when you contact the plan, you want to indicate that she needs to be able to access a provider who is less than 30 minutes away by public transportation. Does the plan have another provider who has availability? And if there's no resolution, you should be contacting the state by making a complaint. And you should also be trying to find out if there is an out-of-network provider available. One other thing to flag is that this provider directory may not be up to date, which is negatively impacting her ability to seek timely care. We would need more information, excuse me, to determine if directory misinformation warranted a complaint to the state. And one other thing, just to put a pin in it, is if this consumer or any consumer can't take public transportation safely, they may need assistance accessing Medicaid non-emergency transportation. So just a flag that Medicaid NEMT or non-emergency transportation is also a benefit in the Medicaid package, although not part of managed care. Okie dokie. What about these? You may have heard talk of these things called single case agreements or SCAs. So your client is enrolled with a Medicaid managed care plan. He's just received a new diagnosis and he'd like to see an out-of-network specialist provider for treatment. Ideally, you want to work with the client to ensure that that the requirements are met in order for the Medicaid managed care plan to approve that out-of-network service before the client actually receives the services. So one is that you want to make sure that the referral to that out-of-network specialist is pursuant to an approved treatment plan. And that would be between the client's or the patient's primary care provider and the out-of-network provider. The other thing that you want to make sure of is that the plan does not have another in-network provider who can provide the same services for the client within a reasonable amount of time at a reasonable distance and time away. So what would happen if this all gets approved is the Medicaid managed care plan will authorize services pursuant to a single case agreement with an out-of-network provider. Okay, at a later date, the client contacts you again. He's having difficulty making continued appointments with that out-of-network provider because the claims that that provider's office have been submitting to his plan have not been paid. So his health plan has not been paying claims to the provider. What can you do? One is you can find out if the authorization for that single case agreement is still valid. If it is still valid, the services are still authorized with the out-of-network provider through the end of the year. Great. One bit of one thought here is that even if the authorization time period is not valid, still, like, let's say the plan authorized services for 6 months, but there is a good reason that the patient needed 7 or 8 months to complete treatment. There is informal advocacy that you can do with the plan to see if you can extend that authorization period. So it's just something to put a pin in. does it matter that the out-of-network provider isn't enrolled in the New York State Medicaid fee-for-service program? No, it actually doesn't. Out-of-network providers under single case agreements don't have to be screened or enrolled in the state's fee-for-service program. And once again, if your advocacy with the plan doesn't resolve this issue, contact and complain to the state. One thing to keep in mind is that, the provider's the one and who is direct, in some ways directly getting the short end of the stick in this way because he's not getting, the provider is not getting paid by the plan. Obviously, that trickles down to the patient, to our clients. But the out-of-network provider themselves can also contact the plan, and there is a special route that New York State providers can take to complain to the New York State DFS or Department of Financial Services about a plan's late or non-payments. Okay. And finally, just a bit about Medicaid fee-for-service. So providers within the fee-for-service program have to be enrolled with New York State Medicaid in order for Medicaid to pay for services prescribed, ordered, or referred, even if the provider themselves doesn't accept Medicaid payment for their services. Remember what I said earlier, though, that this doesn't apply for these single case agreements. Um, Providers who accept Medicaid fee-for-service can be found at this link we provide here. This data set that this link leads to is fairly unwieldy. So, a quick control find can help you try to figure out whether a provider is enrolled in Medicaid fee-for-service. It's also really important to call providers themselves to find out and make sure that this is up to date. So I would do, sort of a belts and suspenders approach. You can look at this fee-for-service listing, but you can also and should also call providers to confirm that they accept Medicaid fee-for-service. And then finally, a little bit about the Medicaid statewide-ness requirement. So one important component about Medicaid is what we call statewide-ness, and that means that Medicaid cannot vary the mandatory or optional benefits offered by someone's place of residence. What that means is it doesn't necessarily guarantee that a beneficiary is going to receive Medicaid covered services in the community in which they reside. That is obviously determined by the availability and accessibility of providers. What it does mean is that, for example, the Medicaid program can't offer unlimited coverage for hospital stays or hospital services in a county that contributes a lot towards the cost of the Medicaid program while limiting coverage in a county that doesn't, etc. There are some, waiver ways to get around this with waivers, but the bottom line is that statewideness means that Medicaid cannot vary the mandatory or optional benefits offered by place of residence. And so with that, I think that is the end of our presentation. Thank you so much for listening, and take care, and we wish you the best of luck in your CHA advocacy.
Now we will talk about network adequacy for Child Health Plus, Essential Plan, and fully insured commercial plans. We'll discuss network requirements and how to resolve network adequacy issues. First, Child Health Plus. The State Department of Health requires that any Child Health Plus plan have an adequate network of providers in order to be able to provide the benefits in the mandated benefit package. The model contract for Child Health Plus, which was last updated a long time ago in 2008, is accessible here, linked on the slide, and there's a more current subscriber contract and member handbook examples that explain what is in the benefit package for Child Health Plus. Child Health Plus plans must consider when making their network anticipated enrollment, expected utilization of services by the folks that are enrolled, the number and types of providers necessary to furnish the services in the benefit package, the numbers of providers not accepting new patients, and geographic location of providers and enrollees. For commercial networks, including CHIP, EP, and QHPs and employer-sponsored health insurance, individual and group plans, network must be sufficient to provide the services covered on the policy or contract in accordance with the benefit package. There must be a sufficient number and array of providers to meet the diverse needs of the insured population, and provide services accessible without delay, including but not limited to at least one general hospital per county, except for in New York State counties with high populations. For example, Erie, Monroe, Nassau, Suffolk, Westchester, Bronx, Kings, New York, Queens, they must have at least three. So in the real populated cities. For counties where there's no general acute hospitals available, the plans must include in their networks the next closest site. The plan must have physicians, primary and specialty care, behavioral health and substance use providers, allied health professionals like immunologists, preventative care specialists, and physical and speech therapists, and ancillary providers like radiologists and supportive care professionals, dental services, DME providers, pharmacists and pharmacies, and home health providers. There's a link here to the 2026 plan invitation, which has updated information about what networks have to look like in commercial plans offered through the New York State of Health, so CHIP, EP, QHP. And there are mirror requirements on the Department of Financial Services website that are in later slides here. So for primary care, plans must offer no fewer than 3 primary care physicians within 30 minutes or 30 miles from the enrollee's home. For metropolitan areas, 30 minutes is by public transportation, the standard. For non-metropolitan areas, 30 minutes or 30 miles by public transportation or car. And for rural areas, transportation may exceed these standards if justified. Plans will assign enrollees to a PCP if they don't choose one, and those assignments must consider the geographic location of the enrollee and the specific healthcare and language needs of the enrollee if the plan knows them. Other types of providers that may be substituted for a PCP are OBGYNs, certified nurse practitioners, or PCP nurse practitioner teams. These plans must also have at least 2 of each required specialist provider type per county where available. So for all other non-PCP provider types, they should be accessible within 30 minutes or 30 miles travel time. Our DFS and NISO guidance from 2026 says that this is preferred, but the 2027 guidance says it's required. And the links to those documents are in this presentation, the most updated one. Particularly in rural areas, the plan may contract with providers in adjacent counties to fulfill its network adequacy requirements. And plans must include federally qualified health clinics and tribal operated health clinics to the extent that such providers exist and are available in each county. For commercial insurance, so QHPs, fully funded employer-sponsored coverage regulated by New York State, for example, they must guarantee that the network has an appropriate choice of providers sufficient to render the services covered by the policy. Again, additional requirements for QHPs include that they must ensure a sufficient and accessible choice of providers, including safety net providers known as essential community providers. The QHP must provide reasonable and timely access to these providers for low-income individuals or medically underserved areas. And they must contain providers willing to accept new patients. And there's a link here to more information on what essential community providers are. And this is from the DFS guidance. It's just a handy chart on what kind of providers are required in commercial insurance networks and how many of them on the right. For dental networks, Child Health Plus, EP, and commercial requirements must include geographically accessible general dentists, including a choice of 2 primary care dentists within each county in the network and a ratio of at least 1 primary care dentist per 2,000 enrollees. Networks must also include at least 2 orthodontists, unless the orthodontic benefit is not covered by the plan, 1 pediatric dentist, and 1 oral surgeon. The network must also include orthodontic surgery, TMD treatment, and oral prosthetics, which should be provided through any qualified dentist. If there is not a qualified dentist with these specializations in the network, they must be provided by referral. Periodontist and endodontist should also be available by referral, and the network should include dentists with expertise in serving special needs populations like people with HIV and developmental disabilities. And the time and distance requirements for dentists for rural counties. Time and distance standard of 45 minutes or 45 miles may be used in the following rural counties for these provider types. So in some of our rural counties upstate, there are a lack of dentists generally, so that there's an increase here in the time and distance requirements for pedodontists, oral surgeons, and orthodontics in these counties. They're allowed to be quite a distance away. And then for vision coverage requirements, DFS requires standalone vision networks to include the following provider types in each county or expanded county borders, each with their own billing number, individual NPI number per provider. 2 ophthalmologists, 2 optometrists, or 1 and 1. DFS does not specify the time and distance requirements for vision coverage, and there's another link to DFS guidance on this. So now that we've talked about the network requirements, we're going to talk a little bit about access rights and responsibilities. For Child Health Plus and some EP and commercial consumers, they must use in-network providers unless they're having an emergency or get a surprise bill, get a referral from their PCP to see an out-of-network specialist, or get prior authorization to see an out-of-network provider or receive an out-of-network service. Consumers with life-threatening disease, chronic disabling or degenerative condition have the right to a standing referral if they need to see a specialist more than once in a specified period, have a specialist act as their PCP, and have access to specialty care centers. So these are the network protections for folks with chronic or disabling conditions to access specialists. If a plan does not have a provider with appropriate training and experience to meet the enrollee's needs or that offers the same treatment as an out-of-network provider, the plan should make or approve a referral to an appropriate provider according to the treatment plan approved by the plan in conjunction with the treating primary care physician and the out-of-network provider. The plan is responsible for the cost of treatment in this case, and the enrollee should only be charged their in-network cost sharing. So we've talked a little bit about this in the presentation, especially in the Medicaid managed care section. Most commercial insurance, or all commercial insurance enrollees in New York State, and Medicaid managed care enrollees, HMO enrollees, have this right to out-of-network providers if the network is insufficient. And we'll talk in this presentation about how to help your client gain access to this, because it's sometimes not easy, especially in the case of access to mental health and substance use disorder treatment. So here's an example. Enrollees have the right to file a plan appeal if an out-of-network provider or service requested due to network inadequacy is denied. The client's doctor, in this case, prescribes a specific kind of physical therapy known as pelvic floor therapy after the client experiences an injury. None of the physical therapists in the client's network have the appropriate training and experience to provide this type of therapy. When the client's in-network doctor submits a prior auth request or a referral to the plan for the client to see the out-of-network therapist who specializes in pelvic floor therapy, the plan denies the request and states that the client can go to one of two physical therapists listed in the denial and in the network. However, none of these therapists are trained in pelvic floor therapy. So in this example, if you know that none of the therapists provided by the plan have the appropriate training and experience to perform the service, you can file a written plan appeal for an out-of-network referral or service denial. And the initial plan appeal after denial of prior authorization should include a written statement from the provider, either an MD or a DO, saying that the in-network providers are inappropriate. If denied again, the consumer has the right to file an external appeal with DFS. Out-of-network referral denials are common. A consumer may win on external appeal because the reviewer could call each of the in-network providers listed in the final adverse determination and see for themselves. And we've had this happen, that the actual providers are either not available or do not have the specialization the plan is saying they have. If the in-network providers listed on the FAD do not have the appropriate training and experience to perform the service or are not actually available, you may win. Unavailability means too far away, being out on leave, having a full panel and not accepting new patients with bad health insurance, having very long wait times or wait times outside of the wait time requirements. And there's guidance here on out-of-network referral and service external appeals, getting to that appeal, and also a lot of information on this type of external appeal in our external appeals training in this certification series. So now we're going to talk about access to mental health and substance use disorder treatment. We talked a little bit about this in the Medicaid section as well. There are new regulations that require plans to make access within specific timeframes based on real problems accessing mental health and substance use disorder treatment in the past in New York State. And these are great strides comparatively, but still a lot of work to be done in terms of access. So we'll talk about how to help your consumer access in-network providers for these services, and how to troubleshoot issues. Plans must ensure that commercial networks, including EP, Child Health Plus, commercial, individual, and group plans, employer-sponsored, and this applies to Medicaid managed care, that they have adequate capacity and availability of mental health and substance use disorder providers to treat its insured's conditions within these timeframes. An initial appointment with an outpatient facility or clinic should be provided within 10 business days. An initial appointment with a healthcare professional not employed by a facility or clinic, so a private provider, also within 10 business days. And an appointment following discharge from the hospital or ER for a mental health or substance use disorder condition, 7 calendar days. These standards can be met with telehealth unless the consumer specifically requests in-person appointments. And this is just a citation here and the link to information about who is considered a healthcare professional under this regulation. So who might be, what kind of provider has this requirements, these timeframes. So what happens if the plan can't meet the behavioral health access standards? If a consumer cannot schedule an initial appointment with a mental health or substance use provider within the regulations required wait times, 10 business days or 7 calendar days, depending upon the appointment type, the consumer can submit an access complaint by phone or in writing. Access complaints, when filed, require that plans locate in-network providers. The plan has 3 business days after the access complaint is filed to locate an in-network provider who can meet the wait time standards and give the consumer the provider's contact information. The plan's response to an access complaint must be in writing. If the complaint was filed by phone, the plan must respond by phone as well. If the consumer requests an in-person appointment, the provider must be located within a reasonable time and distance. Although this is not defined in the regs, we would say 30 minutes and 30 miles. If the plan cannot actually locate an in-network provider within these appointment times who can treat the consumer's condition and can meet the wait time standards in the regs and is within a reasonable distance, the plan must approve an out-of-network referral. Of course, the out-of-network provider must be able to treat the condition, must meet appointment wait time standards in the regulations, and must be located within a reasonable time and distance of the insured. Their rates can also not be excessive or unreasonable. Plans must notify the consumer of this in writing and also by phone, of course, if the complaint was made by phone. And plans cannot impose more than in-network cost sharing on the consumer in this case and must apply the out-of-pocket maximum that would be applied if the consumer was seeing an in-network provider. So if they can't find an in-network provider within the wait time standards for an appointment, they must approve an out-of-network provider and treat the adjudication of the claim as if the provider was in-network. However, even if you win this access complaint by the plan saying that they will approve an out-of-network provider, the work is not done. The plan does not have to provide you info for a specific out-of-network provider. The consumer has to find the out-of-network provider on their own. Clients or their advocates should call the plan or check plan documents to find out what the plan's out-of-network referral process is and initiate it. Usually it's to have an in-network provider submit a referral to the out-of-network provider, and this would be approved by the plan based on the access complaint that they won, but is an additional step. If an out-of-network so the out-of-network referral should be approved following the access complaint. Approval will last until the service is no longer medically necessary, or the plan can locate an in-network provider to treat the consumer's condition, which meets the appointment wait time standards and is within a reasonable distance from the consumer. In that case, care can be transitioned to the in-network provider. And of course, if the consumer disagrees with this decision, they can request an expedited appeal. All this should come with notice and the right to appeal. Some provider directory requirements We're going to talk a bit about provider directory requirements because of a history of um, ghost networks and network directory misinformation for commercial products. Um, there are some pretty good provisions on network directory requirements, and each couple of years they get a little stronger. They were strengthened for behavioral health providers with these new regs, but there's some pretty good network adequacy provisions generally, not just for behavioral health. Um, Generally, plans must verify the accuracy of their network directories at least quarterly. For behavioral health providers, plans must review claims activity every 6 months. And if an in-network provider has not submitted any claims during the 6-month period, the plan has to confirm that the provider is still in network and whether or not they are accepting new patients. Plans must have a publicly available website to report directory errors, a method for reporting publicly, and reported errors must be corrected within 15 days. In 2027, NISO plans will be required to have specific directory dispute resolution processes that they report to the state. The existing requirements for provider directory are in this citation. There's additional new provisions in the regulations specific to behavioral health providers. The directories must include whether or not this is the public facing directories on the websites must include whether a provider is affiliated with any Office of Mental Health or OASAS facility. If there are any restrictions on the availability of the service, so if it's for adults only, for facilities, the level of care offered, inpatient, outpatient, intensive outpatient, for example, the city, town, or zip code where the provider is located, whether the provider offers telehealth, and if it's a private provider, the language is spoken. The directory of mental health and substance use providers posted publicly must be searchable and filterable by these same 5 points. The services provided and conditions treated by the provider, the level of care offered by facilities, the language spoken by providers, affiliation, and location. The plan must provide the consumer or their designee with a list of providers who can treat their specific condition within 3 business days of a request. And some other requirements of the new New York regulations on access to behavioral health. Plans must have designated staff with sufficient knowledge to help consumers find behavioral health providers who can treat their condition. The contact info of these designated staff must be posted publicly on public areas of the plan's website to allow the insured to access designated staff directly. So you should not need a login or a password in order to get to this staff. Advocates should be able to find this staff to help folks find a behavioral health provider. Plans must post this information on a publicly available area of their website, appointment wait time standards, and the process for submitting access complaints. So this is about, transparency of these requirements and the processes by which you use them. And plans must develop their own access plans that consumers are supposed to be using in order to get mental health and substance use access. And plans must certify this information annually to DFS and DOH that they are in compliance with these new regs and report the number of access complaints received and how they were resolved. So we certainly encourage advocates to be using this complaint mechanism and following through with these complaints because, first of all, it's the way to get out of network services authorized for behavioral health, but also it helps the state to understand kind of how systematic this issue is and to remedy it. And here's some consumer information, FAQs and fact sheets on the new regs. And again, these are applicable to commercial, EP, Child Health Plus, and MMC. And then here are some strategies to solve network adequacy issues and a case example. So here is a provider directory misinformation example. A consumer found an orthopedic provider through their online directory and assumed the provider was in network. They schedule an appointment with the provider and receive afterwards an EOB denying the service rendered because the provider was out of network. They call the plan and learn that the provider left the network last year. So in this case, this is actually a surprise bill under the No Surprises Act, the Federal No Surprises Act, and the New York State surprise billing law. And the remedy for this consumer is to file an appeal for network directory misinformation. If they have proof that the directory was outdated, they can file an internal appeal and should not be billed more than their in-network cost sharing. The advocate should also file a complaint with DFS, since it's clear that the plan did not update their website within 15 days required by the law. Although the No Surprises Act does not apply to CHIP and EP plans, equivalent protections exist for provider directory misinformation in New York State law. So it applies to all commercial insurance, really. And we talk about this in our in some of the medical debt trainings and materials, on what is a surprise bill, how to recognize a surprise bill, and certainly bills that are based on network directory misinformation are surprise bills. And these resources here tell you how to resolve them, and they're consumer friendly. So how to figure out if you have a surprise bill and what to do if you get a surprise bill. So for CHIP, EP, and commercial, a second medical opinion is a special protection, and that's for group and individual health insurance enrollees. Generally, all group and individual health insurance policies must include coverage for a second medical opinion from an out-of-network specialist. The second medical opinion must be covered at no additional cost to the consumer beyond what they would have paid if those specialists were in network. There's an example here. Your client is enrolled in a QHP and diagnosed with a rare form of cancer, and they've been prescribed radiation. They want a second opinion on their diagnosis and treatment options from an out-of-network specialist who specializes in treating rare cancers. The advocacy step here is to make sure the client has obtained a written referral from her in-network doctor to the out-of-network specialist, specifying that they want a second medical opinion, and submit that to the plan to help the client request prior authorization for the second medical opinion. This gives the fact that the in-network provider is asking for this and certifying the second medical opinion gives the consumer the requisite and correct appeal rights for external appeal. And then some additional protections for out-of-network doctors and specialists are transitional care requirements. And there's transitional care requirements both in the No Surprises Act and also in our New York State law. We have strong transitional care requirements that were recently updated in the 2026-27 state budget. Consumers have the right to continue to receive care from a provider even when they are not in network for a specified period. This applies to comprehensive health insurance, including PPOs, EPOs, HMOs, student plans, municipal plans, prepaid health service plans. It allows care with an out-of-network or terminating provider for up to 90 days or 60 days for certain new enrollees. So if you are enrolling in if you're a new enrollee in an HMO, qualifying conditions include any ongoing course of treatment under New York State law, serious and complex conditions that are life-threatening, disabling, congenital, or degenerative, pregnancy at any trimester, and the transitional period must include postpartum care directly related to delivery, which can extend beyond 90 days. Scheduled non-elective surgery, including post-operative care or institutional inpatient care, and terminal illness. So all of these folks with any of these qualifying conditions can get continuity of care when newly enrolled in a plan or when a provider leaves the network for up to 90 days or until the plan can find an in-network provider that can provide the service. Providers rendering transitional care must agree to accept the reimbursement rate applicable prior to the transition as payment in full, plus the insurer's in-network cost sharing, and they must adhere to all the insurer's quality standards, policies, and procedures, including submitting necessary medical information to obtain pre-authorization. So this is where advocates come in. Out-of-network providers sometimes have to be convinced to bill out-of-network plans in this way for transitional care. And there's some citations here on this slide to an insurance circular letter, which is very helpful for transitional care requirements and the statute. So here are a couple of examples where at the end of this part of the training, so we're going to discuss a couple of examples. This is how, consumers with network issues might come to you. Here's one example where a consumer cannot find or access an in-network provider. The consumer needs to see an in-network dermatologist, but the closest in-network dermatologist is a 1-hour drive from the consumer's home. A second example, the consumer needs to see an in-network therapist, but none of the in-network therapists are accepting new patients. If the therapy they need is behavioral health, file an access complaint with the plan. Special protection for behavioral health providers. Example number 3, the consumer needs to see a pediatric neurosurgeon to treat a rare condition, but the provider network does not have any pediatric neurosurgeons. So for all of these consumers, I would say except for the behavioral health, although even for the behavioral health provider where you have a special access complaint right, you should be able to go to the plan's website and find designated staff that can help to find an in-network provider. So for all of these providers, a consumer can and should first engage in informal advocacy with the plan, attempting to locate an out-of-network provider that would be geographically accessible or qualified to treat the consumer and is accepting new patients. So first try to find an in-network provider. If not, find that out-of-network provider and help the consumer to submit a written request to the plan with a letter of support from the consumer's physician, explaining why they should be allowed to see the out-of-network provider. And so this is that an out-of-network provider obviously is not available for the first example within the time and distance requirements. For the second example, the therapist is not seeing new patients. And for the third example, the pediatric neurosurgeon does not exist within the plan. After confirming that there isn't an in-network provider and potentially finding another that provides the same service, make sure that the referring provider, the PCP, is actually doing the paperwork to refer them to the out-of-network provider. You obviously need the PCP support here. And remember, if the provider's out of network, the plan will only pay the in-network rate. So there's some advocacy around making sure that the PCP does the referral and that the out-of-network provider is actually willing to take this out-of-network plans rate. A lot of kind of provider cooperation and room for advocacy here. If the client is new to the plan or their specialist is leaving the network and they need transitional care from the out-of-network provider, contact the plan to confirm the details of their transitional care coverage specifically. Every plan must have one. They must be able to provide this for consumers, so they have to have a policy around this. Be persistent. Some don't know that they have to have a policy around this. You may need to assist the provider's office with the proper billing to the plan. If informal advocacy does not resolve the issue, get a written denial and appeal. Make sure that you're submitting information from the doctor on appeal to get yourself and get this consumer to external appeal. If internal and external appeal does not result in the favorable outcome and the plan is not meeting network adequacy requirements, of course, we should be filing complaints with DFS and DOH. And here I have some commercial plan sources of law, and these apply to the insurance law applies to commercial health insurance, including individual and group plans. There's also corresponding sections in the public health law that apply to CHIP and public health insurance plans. So here are the citations for the fact that provider networks must include geographically accessible providers with appropriate training and experience. They must have sufficient providers to render the services, and they must have adequate networks based on time, distance, and provider ratio standards. And these citations talk about the maintenance of accurate specialty-based listing of participating providers, including digital contact info, and whether or not they're accepting new patients. So these first citations are about directory requirements, then special protections for QHPs on network adequacy and essential community providers, protections for managed care enrollees. Those in an HMO have special protections, and for group and individual health insurance enrollees, and then appeal rights for fully insured commercial plans and EP plans, internal and external, and CHIP plans. And then there's some templates here for network adequacy complaints and grievances for commercial insurance, EP, and that includes EP and CHIP. And these will help you to get started on a network adequacy complaint for fully insured commercial plans. If you want to submit a complaint to DOH or to the Department of Financial Services, this has a template which contains citations, and you can just kind of cut and paste what your consumer's contact information is and modify the language in the complaint. There's also a complaint on directory and network status misinformation. So helpful for filing complaints and also in addition to the appeals templates that came with the surprise bill information. And that's the end of network adequacy.